for you to provide feedback to as many of the folks as you can. And you can just email those. If you, Vicki, are you on? If you don't mind to just email them to Vicki and she can compile them to start, since she has been our lend extraordinaire over the last couple weeks. That would be really helpful. Let's see what else. Okay, so Jen sent that form for evaluations. We'll have Courtney go first. And since I was out sick when we learned how to do the, how did we do the timer? Sorry, Jen's, let me undo my, although you guys are gonna see this horrendous disorganized room behind me. No. Jen. Do you remember how to do the, does anybody remember how to do the timer? Because I was not here when we did that.
I remember it was called Blue Sky Timer. That's all I remember about it.
And it was an app, right?
I think so.
Do you know where to add in the app?
I don't see your app options.
Because I'm not the host. Vicki, can you make me the host real quick? And maybe that will help. So just as a reminder, everybody will have up to 20 minutes for their presentation and then up to 8 minutes for question and answer. So it's a 28-minute presentation. So that gives us a chance to get everybody else kind of ready and started next. I don't think this is gonna work. Thank you, Kelly, for putting that in the chat box. I'm just not sure that me downloading it now that we've already started is going to work. I think the host has to do it because we are. No, you still don't see it. Right there. Support. I am host now, but I still don't see, like normally it signs on when we first start, but I don't see it. Yeah.
Yeah, we can't find the app.
I don't even see where apps would be. Options. Nope. Well, you don't see it in here, do you?
I see an apps thing stuff on the lower right, but when I click on it, it doesn't bring anything up.
Oh, you do?
That's where ours usually is.
I don't see it either.
I wonder, I'm not the host, am I? From being on this before?
I don't think so. No. Okay, well, we're going to do it the old school way, and I'm going to hold up 5 minutes. And then I will hold up 1 minute, and then I will come on and say end of presentation. And we will try to get this refigured out for next week. So, Courtney, whenever you are ready, you may begin.
All right, thank you. Sorry, I hear my husband just got on the phone downstairs, so if you can hear him too, sorry. Okay, so thanks for having us, because Amber and I aren't usually part of SEBM because we're doing our research as just our master's thesis separate. So my project is called Genetic and Clinical Predictors of Hearing Loss Among Patients with CHARGE Syndrome. So it's super timely. Thank you, Sam, for giving a great intro to hearing loss. My research advisor is Dr. Kettler, who is the clinical manager of the audiology department at CCHMC. And it doesn't want to go to the next slide.
if you click in it, yeah, sometimes just starting and resharing.
There we go.
There we go.
Okay, so pretty much going to go through the whole project from background to kind of my timeline all the way through to results. And then, of course, plenty of time for questions and comments if you have them. I thought it'd be great to start out with some cute kiddos. These are kids who have CHARGE syndrome and are seen at the CHARGE Center here at Cincinnati Children's. And these kids are featured on the website. So if you want to go and actually read about their stories, you can. So for those who haven't heard of CHARGE syndrome before, Sam just mentioned it. In their presentation, it is a multi-system genetic disorder. It really affects the body top to bottom, inside and out. It can be really severe. CHARGE is actually an acronym. So it stands for columboma, which is a gap in the development of the eye, and it can lead to vision problems. There's heart defects, atresia of the coronae, which is where there is a blocked nasal cavity, and that can cause trouble with breathing. Retardation of growth and development, genital hypoplasia or underdevelopment or abnormal development, and ear abnormalities causing deafness. So typically the prevalence is quoted to be about 1 in 10,000 births. Unfortunately, I will say that not every child born with CHARGE syndrome lives a long time. And there is clinical diagnostic criteria that's available for CHARGE syndrome. So there's certain criteria that kids can meet in order to get this diagnosis. However, there's been a lot of recent research, even research done here at Cincinnati Children's, that shows that there's a lot of expanding phenotypes, so how it presents. So there might be things that aren't listed in this acronym. Maybe kids don't have things that are in this acronym, but they still are thought to have CHARGE syndrome, and we'll talk more about that. Some of the other things that you can see, trouble swallowing, low muscle tone, skeletal abnormalities, cleft lip or palate, learning disabilities or intellectual disability, developmental delay, behavioral challenges, as well as autistic-like behaviors. There's thought to be impacts on the immune system, kidneys, really everything. So that's why I say it kind of affects the whole body. Of course, I'm working with an audiologist, so we were mostly focused on hearing loss, which was very new to me. So I'm glad that we all just had that presentation and I don't have to tell you everything about hearing loss for the first time. So we'll just focus on hearing loss and CHARGE syndrome. It's quoted that over 90%, nearly 100% in some studies of individuals with CHARGE syndrome have hearing loss. Typically, about 50% they're reported to have severe or profound hearing loss, which are the most serious categories. And then, of course, there's auditory intervention available, which we did just learn about. So those hearing aids and cochlear implants, there's also bone conduction devices, and that is great, but there are some extra challenges that come with hearing loss in kids with CHARGE that maybe not an isolated hearing loss. So for one, just diagnosing them, I know we learned about the ABR test, which is awesome, but it does require natural sleep. That, in addition to the medical and behavioral challenges in these kiddos, is extremely challenging. So a lot of times they would require sedation. That's also not great because sedation can be really high risk for these kids because of the breathing trouble, as well as some of the heart defects that we can see. So that's not fabulous. Hearing aids, over-the-ear hearing aids, can be really challenging because ear abnormalities, even on the external ear, are seen. So some kids have underdeveloped ears, so they're really small and you can't wear the hearing aid. Some of them are kind of just shaped differently so that the hearing aids don't work with them. And as we learned, it's really important in your development of communication. So that's why we're focusing on this. And I know that we learned about the Big D community and how they, use different American Sign Language. My words aren't coming to me. They use ASL. But the thing with Charge syndrome is a lot of them also have vision loss or blindness over time. And so, you know, pretty much any sensory information that we can get to these kids is important for their overall quality of life. And then with those structural abnormalities of the ear, we of course have balance issues as well. And you can also often see some really characteristic behaviors where kids will lay on the couch with their head over the seat, or they will kind of crawl with their ear down on the ground, and they're trying to stimulate their a certain part of the ear because of the structural differences. And all of that can impact their motor development as well. In terms of genetics, because I did say it was a genetic condition, the main gene thought to be involved is chromodomain helicase DNA binding protein 7. We'll just call it CHD7. That just shows it's on the 8th chromosome, which isn't super important for this, but it is really crucial in early embryonic development. So of course, when things are just starting to develop and migrate to the proper areas and form, that's why we see problems all over the body. And this gene is thought to explain about 90%, 70 to 90% of Charge syndrome cases, though there are thought to be some other genes involved probably that we just don't know about now. And then I put on here that it's autosomal dominant. So if you remember Carrie's lecture, we talked about inheritance, and we have 2 copies of every gene. With autosomal dominant, we would say that you only need a change in one of those copies in order to have the condition. It's not often inherited. So a lot of times kids with Charge syndrome, they're not growing up to have children of their own. And so most of the time it's what we call de novo or spontaneous change that just arises in a kiddo. But there are some families where it runs in it. I need to move you guys for a second. Okay, so for my research question, it is among patients with Charge syndrome, are there correlations between the degree of hearing loss, type of hearing loss, molecular findings, and clinical presentation? And then I just have each of those defined below. So the degree of hearing loss is categorized as normal, slight, mild, moderate, moderately severe, severe, or profound. And then the type of hearing loss is categorized by conductive, sensory neural, or mixed. The molecular findings include the causative gene, as well as the type and location of the pathogenic variant. And the clinical presentation includes temporal bone scan findings of the middle or inner ear, as well as the presence of like facial differences. So in terms of talking about the significance and why, even bother doing this study is, one, there is just a gap overall in understanding Charge syndrome. The more research that's done, kind of the less we understand about it. And so that's that expanding phenotypic spectrum. So we really want to just better categorize, just keep collecting data on this population. The second gap is that there have been no genotype-phenotype correlations. So what we mean by that is there's nothing specific about the gene changes that we can relate to a particular symptom or presentation or severity. And it would be nice to have that, of course, because then you could have some predictions that you can make. And then because of 1 and 2, the third gap is that it's difficult to guide family expectations, especially when it comes to hearing loss. Flip of a coin if they're going to need hearing audiologic intervention. We really don't know how well that will work. We don't know if they're also going to be blind. So all of those factors coming together. So for the design of our study, we wanted to do a retrospective chart review because here we do have the Charge Center, which is, I believe, the only one in the country. So our sample population were patients within our Charge Center here. And then of course the target was generalized to individuals with Charge syndrome. We really we didn't have a lot of inclusion criteria. So they needed to have an electronic medical record that we could access. They did have to have genetic testing, so a molecular diagnosis of CHD7 positive charge. So a gene change in that gene that explains the charge syndrome. And then just to kind of give us an age range, we did look at kids 21 or younger, or individuals 21 or younger. Just some more details. Our actual data abstraction was conducted manually, mostly by me from Epic, and then stored in REDCap securely. We got demographic info, hearing loss info, genetic. I did have an audiological fellow read the temporal bone scans, and then of course the facial differences as well. A lot of this was really tricky to get because the kids are being seen by children's, but they don't necessarily live here and they're not necessarily been seen here their whole lives. So most of the records are from outside institutions. So all of this information is in different places for every kiddo. So it was definitely a bit challenging. So as for the timeline, my IRB, I just had to update an existing one. So that wasn't super challenging. That was done last November and 2 Novembers ago. And then we did data collection over the summer, and data analysis kind of started it in the fall, still ongoing. There's always more to look at. My thesis is due to UC at the end of March, and then I will defend it. And then we hope to publish maybe in the Ear and Hearing Journal after that. Okay, so we have most of our descriptive results already. So we ended up with 57 total participants. Again, this is a pretty rare condition, so that was pretty good. And they all did have molecularly confirmed CHD7 positive charge. Pretty even split between males and females. However, most of our participants were white and non-Hispanic. The average age of charge syndrome diagnosis was about 2 years old, or 26 months. However, that ranged from 0 months to 175 months, which is 14.5 years. So that just goes to show that this diagnostic odyssey can be really huge and frustrating for some families. And we'll kind of talk about that in a little bit again. As for hearing loss, our data was consistent with previous literature that showed, over 90%, close to 100% have hearing loss, because 90% of our participants did. So to go into the hearing loss info a bit more, 95% had hearing loss in both ears. The most common type of hearing loss was sensory neural. And then most individuals had either severe or profound in their worst ear. So at least one ear with one of those more serious degrees. As for genetics, this does get a bit complicated. So there are some genetic conditions where there's a gene that's known to be causative, and then among people with that condition, there might be 2 or 3 common gene changes that are seen. And so what you can do from that point is kind of group them together by the gene change that they have and look at their presentation to see is there any kind of differences. With charge syndrome, it is not like that at all. Nearly every individual has their own unique gene change. And so that makes it really hard to compare. So instead, we kind of grouped the gene changes by the type that they are and the functional effect on the protein. So for example, the nonsense and frame shift types would have a greater effect on the protein because they kind of end up not making the full protein to begin with. Whereas something like missense is just a small change of an amino acid. So we think of them as letters. So it's like changing an A to a G, in which case most often the protein itself is still made. It just has that minor change. With all that being said, really the takeaway here is that the majority of our participants did have those more serious changes, which would be expected in our field. And then getting back to that diagnostic odyssey, you can see that patients had anywhere from 1 to 4 different genetic tests ordered over a range of years. And so for me, I would be interested in kind of doing further research. I think it does warrant more research in the future to look at kind of the diagnostic efficiency that we have and what type of genetic testing is going to be the most useful and the quickest. So this is where we're still doing stats. We want to do some comparisons between the type of hearing loss as well as the type of genetic variant. Nothing here is really standing out or jumping out at us. And so I would say that there is probably not a genotype-phenotype correlation with CHARGE syndrome, which was kind of to be expected, but it's good to have the info. Something that was interesting was that those who had more of those facial differences that we looked at, so things like cleft palate, small eyes, they were more likely to have severe or profound hearing loss. And then I know we were asked to kind of relate this to our leadership competencies. So just thinking about the first one, the knowledge base, I think, of course, the promotion, it lists on the website that it's the promotion of health and well-being in medically vulnerable populations. I certainly think this would include CHARGE syndrome patients. And really our study was just to learn more about it and to better describe it. I think we all agree that critical thinking is required in all of our research projects, especially in kind of thinking about the results. And then the one that really stood out to me for my project was the family and professional partnerships. I think the whole goal of the project is to gather more information for families, allow us to tailor recommendations. And even if we didn't find that, you know, at least we tried for them. References, and then I will take any questions or comments that you have. Thank you.
Thanks, Courtney. Well within the timeline. We'll open it up to questions for a few minutes.
I just want to say, Courtney, what an important project this is, and
Thank you.
such a nice, thorough job explaining everything you're doing. You've got a great sample size.
Thank you very much.
I don't know if you saw the chat, Courtney, but Nicole asked if anyone's looked at epigenetics with CHARGE syndrome.
That's a great question. I am not. I think Brittany Simpson might be starting to. I'm working with Dr. Simpson, who's a geneticist, and she does a lot with epigenetics. So if anyone's doing it, she will. But for my project, no.
Have you gotten at all much to interface directly with any of the families via? Yeah, no.
No,
They're just such fun kids.
I know. I'm still trying to. I'm hoping my very last rotation will allow me to meet some of the kids, and yeah. So hopefully.
Excellent. Lots of shout outs in the chat box. It's always so helpful when you all genetic counselors and audiologists and pretty much anybody in the LEND program explains things in ways that others in other disciplines can understand. So we appreciate that. Great. Well, that will move us to Amber then.
Great.
All right.
Does this look good? We good to go? Okay. Awesome. Yeah. So my project, like Courtney said, she and I are doing graduate thesis work for our master's. And so my project is behavior and Rubinstein-Taybi syndrome. And these are my research advisors. I just wanted to throw them up because if you remember from past lectures, you'll see a lot of DDBP names on here. So my primary advisors are Dr. Brittany Simpson, who Courtney just mentioned. She's a geneticist at Children's who focuses a lot on epigenetic disorders. And Diana Brightman, who's a genetic counselor who works pretty closely with Dr. Simpson. And then we also have Ilka Riddle, Lauren Schmidt, and Celia Schilmer, who all work for the DDBP, and a couple of them have given us lectures before. Lauren Schmidt is a psychologist, but she is actually doing most of our data analysis. So she's been awesome to work with over the past couple of months. And then Dima is a CRC who works for Cincinnati Children's, and she's helped with a lot of our red cap use and things like that. So I just wanted to start off by talking a little bit about Rubinstein-Taybi syndrome, which I'm going to abbreviate RSTS because it's a little bit easier to say. It's called Rubinstein-Taybi syndrome because two doctors who discovered it were Dr. Rubinstein and Dr. Taybi, and so they named the condition after them. And Dr. Rubinstein was actually a doctor here at Cincinnati Children's. So Cincinnati Children's has a long history with this condition, and that's part of why I'm looking into this condition, because they've been caring for this patient population for quite some time. You can see that it's an extremely rare condition. So 1 in about 115,000 children is born with Rubinstein-Taybi. And traditionally, it's been described as having 3 main features, being developmental delay and intellectual disability, broad thumbs and big toes, and then characteristic facial features. And I put up here 3 pictures. These are 3 kiddos who are seen at Cincinnati Children's, and they all have stories. You can read about them on Cincinnati Children's website. You can kind of see that they all have a very distinct facial feature that kind of goes along with it. I've gotten to meet a couple kiddos with RSTS throughout this project, and that's been really fun. They're always a good time to hear what they have to say and bring to the table. So this is a slide kind of just talking through some of the background of the condition. There's 2 types of RSTS. Type 1 is caused by variants in the CREB-BP gene. That's the most common type of RSTS. Accounts for about 50 to 60% of all cases. Type 2 is caused by the EP300 gene, and that accounts for about 8 to 10% of cases. There's some literature out there that suggests phenotype, like the symptoms that individuals experience with type 2 are slightly milder than with type 1, but that's not really fully understood yet, so we can't see all of that for certain. And you'll notice that 60 and 10% do not add up to 100. So there's still a good portion of individuals with this condition that do not have a molecular diagnosis. So when they did genetic testing and looked at these genes, there were no changes, but clinically they meet the features of RSTS. So there might be another gene out there we haven't found yet that also can cause RTS. Both these genes, they code for histone acetyltransferases, which is a big word, but it's basically a way of saying that they control other genes. So instead of that CREB-BP and EP300 gene being in charge of one system each, what they actually do is turn other genes on and off. And so when CREB-BP and EP300 stop working, then all of those genes that they are supposed to be turning on and off suddenly are no longer regulated. And so you end up with problems all throughout the body. So this is what we call epigenetics. So this syndrome it's a little bit of a complicated molecular background because we call it an epigenetic syndrome. So those changes and things that are happening, it's because these genes that are at fault for this condition control so many things in the body. So you'll see, just like Courtney was talking about with charge, how it's multi-systemic, very much the same thing going on here with Rubinstein-Taybi, where lots of systems are affected by only one gene being, or with only one gene having an issue with it. So if you have questions about that, let me know because it gets a little confusing, but just think of them as controller genes. And when the controller stops working, problems happen in the rest of the body. So some features of the condition early on in life, these kids struggle with feeding. They're typically very small. They don't keep weight on. They have lots of growth delay. They may have immunodeficiency, so they get sick really easily. Sleep apnea, problems breathing, they may be born with heart defects. They have lots and lots of GI problems, and they're typically super friendly and outgoing, kind of want to be in the action. Later on in life, some of these things start to change. So instead of struggling to keep weight on, they gain weight rapidly and struggle with obesity. Some of that friendly personality might change and they become a little bit more aggressive, have some more obsessive, compulsive behaviors. Those GI difficulties will kind of stay with them throughout life, although they might change as, with time throughout their life. Some of these kids communicate really well, and you can have whole conversations with them, although they may be a little bit delayed or have a limited amount of understanding of what's going on. Some are completely nonverbal and may use iPads or other things like that to communicate. Typically, IQ for these kiddos is maybe between like 40 and 60, but it's really super variable. So I've seen studies where it'll be as low as 30, and then studies where it'll be up in like 70, 80 as the average IQ. So definitely super, super variable. And then behaviors. So at the beginning, I said my study was on behaviors. I haven't really talked about those yet. Behavior is really, we all know, key factor in the quality of life. And in RSTS, there's not been a lot of research done on behavior. The research that has been done is often on very small sample sizes, which is understandable considering how rare the condition is, but just means that we need even more studies to understand better what behavior is actually there. Many of them use limited measures, so maybe only one survey or one way of measuring behavior, when really we'd like to see multiple measures used so we can get a better idea of what's really going on. And then most of the research has focused on children. So there isn't a lot of behavioral studies done looking at older individuals. And part of that is just because we haven't known about this condition for that long. So it's a lot easier to find a child who's been diagnosed with this than an adult, because maybe the adult doesn't even know that they had this condition, because this condition wasn't known about when they were a child and getting seen by a doctor. But the population of adults is growing as this condition gets older and older. So like I mentioned prior, the behavior does tend to follow some path of change over life, but it's not well understood like why that is or exactly what age changes start to occur. So that's one of the things that we wanted to explore in this study, was what's the age-related change with behavior in RSTS. There's one study, I listed it here, done in 2012, that found that age-related change, but that's really the only one out there that has looked into that. So we really wanted to dig in a little bit deeper and see if we could find similar things to them and what that looked like. Also, some of the providers at CCHMC had a clinical suspicion just from patients they'd seen that there was going to be differences in behavior between males and females, which has not been reported in the literature at all, but that was one thing they wanted to parse out in this study. This is just a list of behaviors that have been reported in this population. I'm not going to read through it for the sake of time, but lots of different behaviors. So we use this list to tailor how we designed our study, which you'll see in just a moment. Our goal was really gather information about behaviors present in individuals with RSTS over a wide age range. And then we wanted to take that data and look for patterns relating to changes in behavior that correlated with age of the participant and sex. And we wanted to do all of this with the goal of ultimately adding to the literature on Rubinstein-TB and providing clinicians and families with more information about what to expect regarding behavior as their child grows up. So that was our overarching big picture. So what we decided to do was survey caregivers of individuals with RSTS, and we use these 4 measures listed below. Some of you might be familiar with some of them. The Yale-Brown OCD scale is kind of the gold standard for diagnosing OCD, and we used it in just a measure of saying how many behaviors are present of OCD rather than does this participant or this patient actually have OCD? Because to do give them a diagnosis, you have to have a clinician administer that measure, but we just used the self-report questionnaire to get an idea of where they fell on a spectrum of behaviors. The ABC2 checklist is looking at abnormal behaviors that are present. The anxiety checklist is looking at anxiety-related behaviors. And then the Vineland Adaptive Behavior Survey was kind of our biggest survey we administered. It's the longest one on this list. And it's really looking at how our children adapting to their life based on the skills they have, and how does that compare with other children of their own age. And that Vineland one also, it basically tailors the questions to the age of the participant. So it's a little bit more unique. It's administered through its own portal, and they use previous answers to kind of give you then your next question and come out with a pretty comprehensive report. So our goal with this was to get 50 participants. We did need IRB approval, but we were able to house this under an IRB that was already approved. So all we had to do was submit an amendment, which was nice and pretty easy to do. We advertised this study on different Facebook support groups. We utilized the DDBP staff who work with some of these families. And then Dr. Simpson also had a lot of contacts through her work and different patients and families she's seen. So we spent some time advertising over the summer. Then we consented participants over the phone or in person if they were coming into clinic for a visit, and followed up that consent process by emailing them a link to fill out our surveys, which was all done through REDCap. We collected all the results in REDCap and scored the surveys. The Vineland data, that's the one I mentioned, was done kind of through a different platform, was a little more complicated. So we used their third-party website, which was called Q Global. And then I went back and transferred all that data into REDCap so we could keep everything in one place. And Lauren Schmidt, who I mentioned earlier, who works for the DDBP, has been taking that and doing a lot of statistical analysis for us. Some of our challenges so far, we only were able to recruit 38 participants instead of 50, which is still pretty good for the prevalence of this condition since it is so rare. So we were okay with that number because of this quick timeline that Courtney and I are on, where we have to turn it in by March 21st. We're a little limited and we had to set a cutoff date for who could enroll in the study. So we ended up with 38, which was good. But it did mean some of our analyses were a little underpowered, so we weren't able to do every single analysis that we had thought we might be able to try out at the start. And then we did have a little bit of issues along the way with some missing data. So some of the participants didn't answer every single question on every survey. So then we had to figure out how are we going to score it and all that kind of stuff. But thankfully, Lauren was very familiar with what to do in that situation, and she helped us come up with some good ways around that. And then here's some of our results. This is just the demographic table. So you can see we had a pretty good split of males and females, and also a good split of the types. So down at the bottom in the genotype box, you can see we had 14 who were the type 1, 10 who were type 2, and 14 who were clinical. So that was kind of nice because it let us look and see, did we find any differences between type 1 and 2, which we did not so far in our studies, our analyses. But what I want to focus on, because we had 4 surveys, you can imagine we just have a lot of data. So I didn't want to show you guys just like chart after chart of all the information because that wouldn't be very exciting. But we did find one really interesting finding. This is a lot, so don't think you need to understand this table. I'm going to walk you through, but you can see on the left side, we have all of the 4 surveys. So these are just the abbreviations for each of the 4 surveys we used. We broke down our sample into males and females. So this chart is only looking at the female data that we have. There's no male data included in this analysis. We broke the females into pre-puberty and post-puberty. So we had 9 pre-puberty females and 3 post-puberty females. And then we looked and said, are there any differences in behavior between those post-puberty and pre-puberty females? And all these little boxes you see are just the different breakdowns of each measure. So the ABC2 had 5 different subcategories. So we looked and said, is there a difference in, social withdrawal behavior between pre-puberty and post-puberty females? And we found that yes, there was a significant difference. So every box that's highlighted shows where we found a significant difference in behavior from the post-puberty and pre-puberty females. Hopefully I didn't confuse you all with that. What was really interesting about this is that we did not find this same trend in the males. There was no difference in behavior from pre-puberty and post-puberty males. We only saw this in the females. So this was interesting because it showed us we did have that increase in some of these behaviors over time that we thought maybe we would find based on prior studies. But we also found that there was a difference in male and female behavior because the females worsened while the males didn't. So you may not be as excited about that as we were, but we were really happy to see some interesting results come away from this. And so this is just kind of some takeaways that behaviors increase in females as they get older. These are the 4 main behaviors we saw that increase in: obsession, irritability, compulsion, and anxiety. We did not see an increase in behavior in males as they got older. And then there is still more data. We haven't finished running all the analyses that we are planning to run, but at this point, these are kind of the main takeaways we're going to focus on in my manuscript so far. And then just to relate it back to some of this MCH competencies, this, like Courtney was saying, really is just promoting better family professional partnerships where we can give families a lot more information about what to expect in their children and help them understand their child's diagnosis even better. Next steps is I just need to finish creating figures and graphs and writing out my manuscript. And like Courtney mentioned, our UC deadline is March 21st for this. And after we submit it to UC and I defend it, we'll probably go back through and edit it a little bit to make it appropriate for a journal submission. And Dr. Simpson's goal is to submit this to the Journal of American Medical Genetics at some point this year. So these are my references, and I can take any questions.
Good job, Amber. Well within the time range. So we'll open it up for questions. I had to chuckle. So Megan's comment is, great job, Amber. It's interesting that the trend of increased behavior in older children do not occur in males as well. And my chuckling to myself was, yes, because puberty for females is awful, but it's also awful for males. I'm sure. I just never have lived that.
That's so true, Steph. I have to.
Right.
Yes.
I agree. I don't think there's many changes for males, and also societal expectations might have, even though there might not be some of the ways that other external factors could also have some of those as well. Not that it's one or the other, or that it has, but it's not out of maybe. Sorry.
I think that's a really good point too, Jason. And that brings me to my question for you, Amber, is what made you guys decide to use the ABC to look at behavior versus another general behavioral measure, like the CBCL or something like that?
The CBCL has been used in many studies in this population. So majority of the studies looking at behavior use the CBCL. In fact, almost every single one that I can think of used that measure to look at behavior. So not that it wouldn't have still been useful in our population to use that to compare results, but we were interested in just like, what would another measure say and what might we find out by using something else? And to be honest, we actually used Celia's input on this. So we asked her, like, what would you recommend using with this population, since she is really familiar with it. She runs the DDBP support group for RSTS here in Cincinnati. So we kind of deferred to her expertise in which measures to use, and she suggested that one. So we were like, okay, we'll go with that one. So that's kind of the best answer I can give you there.
Do you have an idea? I know you said you wanted to get to 50. Do you have an idea of what you might need in terms of numbers of males versus females for feeling comfortable about submitting for publication?
So 50 is what Dr. Simpson wanted to get to for publication, and Lauren Schmidt was we've been talking with her. She kind of feels like we could submit with what we have right now, and it would be accepted because it is such a rare condition, but we could also just hold off, and they've kept our surveys open. So even though I cut off data collection for my project, they are still enrolling participants and having them answer those surveys. So once I submit to UC, Lauren can go back through and update our data with additional participants that have added. So we might wait a year or two to actually submit for publication to see, like, could we get more like 50 or 60 participants to kind of get better and stronger numbers? Because if you remember seeing in our chart, we only had 3 post-puberty females in that, and that's not a lot. So
and you're going to get a reviewer that's like, what can you draw conclusions from with 3? So even if you double that, that would be, and again, this is such a rare condition that 6 could give you a much more indication of what's maybe truly going on. But it's hard because these kids are all over the world and they come to Cincinnati Children's for their care.
It's really,
and of course, because of COVID, we were supposed to have an in-person event, I think this last year in 2021, that probably
we were going to try to have somebody there to like promote our study, and then we were like, well, so I've gone to the online support group meetings.
Good.
And been able to talk to families there, which has been really good. But it's difficult because even in the online support groups, some of those families are joining from Europe, and I'm like, I
middle of the night for them
study right now. So so it's just hard to find people.
Other questions? Well, thank you guys. These are 2 conditions that we don't cover nearly enough in LEND, but thank you for filling those gaps. So it's been about 50 minutes. Do we need a 5-minute stretch break, or do we want to? Yeah, I'm seeing a couple nods for a 5-minute stretch break. So we'll come back at 3:55 and jump in with Emily Schwer's team.
should I just try to share it now?
What'd you say?
Yeah, go ahead and share it.
Okay. Do let me know. Okay, so just to let everyone know, Alex is not with us today because she's busy with her interview. So we're really happy for her and send her good vibes. She did record herself. So you're gonna see her cute little face in the bottom right corner as she speaks. Do let me know if you can't hear anything because I might mess up the audio part of this. So, okay, it says shared, so it should be working. Do you guys see that, my shared screen?
Yep.
Yep, go ahead whenever you're
Hi
ready.
everyone, happy Thursday. Welcome to our presentation on our awesome SEBM project. I'm here with Elodie and Kelly and our awesome project leader.
I'm
So
so
let's
sorry.
get started by talking a little.
That's me. That was me. I'm so sorry. I'm gonna restart that.
Hi everyone, happy Thursday. Welcome to our presentation on our awesome SEBM project. I'm here with Elodie and Kelly and our awesome project leader, Emily. So we'll be talking about evaluating computerized assessment of cognition in Down syndrome with caregiver administration. So we're looking at computerized assessment, looking at those thinking skills with individuals with Down syndrome and what that looks like when caregivers are the administrators of these tests. So let's get started by talking a little bit about Down syndrome, also known as DS. So Down syndrome is the most commonly occurring chromosomal condition and the most common neurogenetic syndrome associated with intellectual disabilities. Approximately 1 in every 700 babies in the United States is born with Down syndrome. And this occurs when an individual has a full or partial extra copy of chromosome 21. This additional genetic material alters the course of development and causes the characteristics associated with Down syndrome, such as intellectual disability. There are 3 types of Down syndrome to note. One is trisomy 21, and that's the most common type, and that accounts for 95% of the cases. Also, there's translocation and mosaicism. In this slide, you can see some of the common physical characteristics associated with Down syndrome, and we'll talk more about those medical conditions that individuals may experience. It's important to note, though, that Down syndrome occurs in people of all races and economic levels. And like I had mentioned, people with Down syndrome have an increased risk for certain medical conditions, and those include congenital heart defects, respiratory and hearing problems, Alzheimer's disease, and thyroid conditions. These health challenges are treatable, so many people with Down syndrome lead healthy lives. The life expectancy for people with Down syndrome has increased dramatically in recent decades, from 25 in 1983 to 60 today, which is pretty great. In thinking about those cognitive and behavioral traits of an individual with Down syndrome, common areas of challenge that are often observed include delays in cognitive skills, verbal skills, and motor skill development. Overall, every person with Down syndrome is a unique individual, and many possess these characteristics to different degrees or not at all. People with Down syndrome attend school, work, have meaningful relationships, vote, and contribute to society in many awesome ways. So let's dive into a little bit about the project. And the project's larger purpose is to evaluate computerized cognitive outcome measures to identify a set of tools or assessments that are best suited for studies that look at treatment in Down syndrome. These assessments or tests look to identify the cognitive and thinking skills of an individual in a standardized way. So early on, the study looked at many measures, and those that were picked for the study were ones that could be given on an iPad to assess attention and executive functioning, or those planning and inhibition skills. This project also investigates caregiver-supervised administration of the iPad assessment to allow these tests to be used at home to measure a person with Down syndrome's cognitive abilities in future studies. A practical application of the study considers participant burden. Finding the best ways to train the caregiver will allow for families to participate in studies from home and improve the current standard of assessment with this population. This research is needed and so exciting, especially given a pandemic and kind of doing these tests at home. And similar studies in the past have looked at telehealth-based behavioral assessment for infants with Down syndrome and then language in individuals with Fragile X. So as I mentioned, individuals with Down syndrome are likely to experience cognitive challenges. And to better support individuals with Down syndrome, interventions targeting cognitive skills are being developed. Clinical trials are also including more individuals with Down syndrome thanks to a portion of NIH funding allotted to Down syndrome research called DS Include, which is really great. These clinical trials often require multiple follow-up visits with the family traveling to the research site. To mitigate this participant burden, clinical trials are incorporating telehealth assessments so that testing can be completed at home. You'll see in our study description how the current project is supporting the development of standardized telehealth administration procedures. You will also see that this project uses computer-based measures. Computer-based measures are a good fit with the nonverbal strengths of individuals with Down syndrome. The measures also are appropriate for a range of developmental levels, another important component of measurement selection because of the variety of cognitive abilities of children and adults with Down syndrome. So that's a little bit about the background of the study. And next I'm going to send it to Kelly, who's going to talk about our community partners.
All right. So at the beginning of our project, we had the pleasure of meeting with the Down Syndrome Association of Greater Cincinnati to get a better understanding of their organization. And their mission is to empower individuals, educate families, enhance communities, and together celebrate the extraordinary lives of people with Down syndrome, and also to create a community that embraces, supports, and inspires individuals with Down syndrome to live a healthy, self-determined, and fulfilling lives. So as policy partners, they played a large part of recruiting participants for our study. They service Southwest Ohio, Northern Kentucky, and Southeastern Indiana. They receive funding primarily through special events such as the Buddy Walk, as well as donations and foundation support. The organization is composed of 14,000 individuals with Down syndrome of all ages, 3,000 family members, and over 300 local professionals. The staff does a wonderful job of connecting families to other resources, such as medical providers. And during our meeting, the staff shared different challenges they faced with COVID, like Alex was kind of mentioning, and they had to be really creative with their programming, such as starting virtual groups. They also highlighted that the Early Matters programming was hit the hardest, and I'll go into more detail about that in the different age groups on the next few slides. So the Early Matters coordinator, Maggie Rands, is the first point of contact for the families. She personally meets with the families whenever needed and offers continuous emotional support. She introduces families to local agencies such as the Thomas Center for Down Syndrome here at Cincinnati Children's and early intervention programs and other county services. She provides consistent quality programs focusing on speech, language, feeding, motor, and sensory function, and connects relatable families to each other through in-person opportunities, online chat groups, and a lot more. She educates and advocates for patients with Down syndrome by meeting with health professionals, especially those that deliver a diagnosis of Down syndrome and or care for children with Down syndrome. As children enter the school system, educational issues become a priority for the families. This is where the School Age Matters coordinator, Joni Elfers, jumps in. She attends IEP meetings or any school meetings to advocate for the students' best interest. She assists families in the preparation of IEPs, behavior plans, or other school-related documents. She organizes peer presentations in the classroom setting to enhance both the student and teacher's understanding of Down syndrome. She introduces families to local agencies such as, again, the Thomas Center for Down Syndrome and county services. She plans and implements their one-on-one tutoring program with special education teachers, and as well as the I Can Bike program, which is through the I Can Shine program. And then we have Stephanie Bear, who is the Adult Matters Coordinator, and she focuses on assisting families in the preparation of future planning documents, provides consultation on topics such as housing, full employment, transportation, healthcare, social networking, and aging. She delivers consistent quality programs focusing on therapeutic, recreational, educational, and social opportunities. She plans and implements her signature independent living retreat, connects relatable families to each other in in-person opportunities, chat groups, and more. She advocates for all adults by meeting with healthcare professionals, legislators, and employers. She researches and forwards resources, referrals, best practices, and community opportunities. And then when meeting with them, they also mentioned that there is an Aging Matters coming soon, which is great to know, just because I feel like through our time here at Lind, we have learned that there are a lack of resources in the aging process, and it's important to highlight that. As well as one of my favorite parts about meeting with the policy partners is they shared about a virtual cooking group that they had started during COVID. And I was able to offer this to one of my patients with Down syndrome who wanted to learn simple cooking skills. And he now attends that cooking group monthly and really enjoys it. All right, so our goals for this project included to describe caregiver supervised administration through behavioral coding of parent behaviors and child behaviors during a computerized cognitive assessment, and to compare parent and child behaviors to child performance on the computerized cognitive assessment. So going into some more details about our project, this study is working directly with patients or human participants. Therefore, it was necessary for this work to be reviewed by the Institutional Review Board, or the IRB. This governing body makes sure that the research study is ethical. So we had to complete additional city trainings to make sure we were all trained to conduct ethical and safe research. After training, all of the members were added to the IRB and we could start coding. It's important to note that this study was thoroughly explained to all the participants and consent was obtained. And in this type of research, if a participant does not agree or drops out for any reason, they are free to do so. The method information included a computerized cognitive assessment completed with at least 25 children and adolescents with Down syndrome aged 10 to 17 years old. We currently have 19 children thus far in the project. The parents completed a caregiver report questionnaire to assess adaptive behavior, cognitive skills, demographics, medical history, and parent characteristics, and participate in a computerized assessment with their child. The child participates, completes a brief set of direct cognitive assessments with the researcher to assess overall IQ. Measures were selected to be appropriate for children with intellectual and developmental disabilities, and all computerized measures are available through iPad apps. And now here's Elodie going to discuss our project progress.
Can you hear me? So as for our progress, as we went along with the project, we met with the policy partners, which was previously mentioned, to gather more information about the Down syndrome and the association. As a group, we did collect the portion of the broader story that we were going to focus on for our SEBM project. And we met in order to create a coding scheme, which we will see an example of on the next slide. We began coding individually and then coming together as a group to discuss the inter-rater reliability. Emily would do like percentage reliability between us, and then we would talk about where we coded for what compared to one another. As we saw what we were coding and where and what the difficulties were, we started adjusting that coding scheme in order to make it more feasible. We eliminated those codes that we seemed or understood were too complicated to code for in themselves, and those that we didn't really find have much meaning for our study. We also are currently in the phase of finalizing that coding scheme as we see more videos and code them, and finally determine what we're going to code for and how, so that it's reliable between each of us. The NIH toolbox for assessment of neurological and behavioral function is a set of brief psychometrically sound measures to assess motor, emotional, sensory and cognitive function in people aged 3 to 85 years old. For our project, we're looking at the flanker task, which is the one on the left, which measures inhibitory control. Children are required to select the arrow that matches with the arrow of the fish in the middle of the picture. Sometimes the fish to the right and the left of the middle fish are pointing in opposite directions, making the task a little more difficult for the children. This is what our screen looks like when we are coding for the videos. So to the right, you will see what the codes are. And this is what it looks like to us. So those are the different codes. And as the video goes along, we start clicking on what behaviors we see in the video. And to the bottom, you'll see how it looks like once we start coding those. As for the codes in themselves, there are two different kind of codes. Those that are subject to like duration. And in our case, we had attention and inattention that were duration, meaning that they were also mutually exclusive. So either the kid was paying attention or not paying attention. And then the other ones are in a point in time. So they measured the frequency in which those were happening. As for coding scheme examples, we looked at the child's attention, whether their eyes were on the iPad or they were looking away from the iPad for longer than 2 seconds. And this was a time frame that we had to determine as we saw videos along the way, how much time we were gonna think was important for us to say, yeah, he is definitely not being attentive to this activity. We also looked at caregiver vocalizations, whether they're giving a positive comment, meaning good job, you can do this, or negative comments, or you're not trying, you're not doing this well. And a few other behaviors that we did look for was also child vocalizations, whether they were positive, negative comments, iPad movement, whether it was away from the table or just caregiver movement of the iPad, and caregiver instructions, whether they were repeating the instructions that were said in the first place or giving additional instructions outside of what was given. So to transition from that, as with any other research project, we encountered a few many challenges. The first one was waiting to be added to the IRB that Kelly mentioned in order to be able to watch the videos and start coding. And that was a necessary first. After that, determining which behaviors to code for or not and to what extent was a little hard at the beginning, but we managed to get through that. And by to what extent, I mean the definition per se of what we were gonna code for. So like I said earlier, the definition of what inattention was exactly if it was longer than 2 seconds away from looking at the iPad, that meant inattention. And so what vocalizations, either from child or from the caregiver, meant that that was a good comment or a negative comment. So those were important and a little challenging at first. Also, while watching the videos, another challenge we faced was determining which behaviors were significant enough to code in themselves, because as we see, every child is different, and we had to find something that was a common ground where the behaviors were quoted for meant something and were not just random to a single child. Another big challenge was inter-rater reliability and working on how we saw things and how we interpret them in order to code correctly, and actually kind of bringing all of that together so that we were all coding for the same thing at the same time. So that has been a work in progress, and we're finally finalizing that. And as we went along the way with that, we removed some of the codes because they were a little bit too challenging or didn't really mean anything at that point. Another challenge was working around our very different schedules, and so that we could all do our part in coding and participation in the project, sorry. And also the Noldus XD is an expensive material, and that's our software there are only 3, I believe, USB keys that are available to us, and that we don't have access to it all the time, and we don't have access to it remotely, so we could only code at work and from work only. So these are our next steps as we go along. So for most of the month of until February, the end of February, we're going to continue coding and finalize the 19 videos that we have to watch. At the beginning of March, we're going to start exporting and analyzing the behavioral data and do the parent forms to answer the research questions. And then we're going to interpret the results, start preparing the poster so that we can finalize the edit by the end of March and have the poster and the abstract ready and practice the presentation the first week of April. That way, when we go to the Night Hunger Center trainees, we can present that poster so well and plan to spend the day in Columbus. We did want to thank the Rubenstein Foundation for funding this project. It wouldn't be possible without them. And this is us because we're beautiful. And if you have any questions, feel free to ask or any comments. And these are references for our activity trip at Columbus.
That was exactly on time. So great job staying to the time limit. And now we'll start in with questions. And I think there was one in the chat. Let's see. I think it was Kim put in, this may have been said already, but did the participants know beforehand they were going to take the test that they would be recorded, or did they just find out after? I know there is a bias in psychology, forgetting the term, that we act differently when we know we are being watched.
The bias is observer bias, but I'm not sure. Go ahead, Kelly.
Oh no, if you would see the room setup, the camera was right there. So there was definitely, they were aware of being filmed, and they, parents and caregivers, I think, walked them through that because they had to sign on to everything. I will say, and this could be completely wrong, but I don't think they cared at all. Elodie, I don't know if they didn't seem to be bothered by the camera, and they definitely did not hide behaviors during the assessment, that's for sure.
I feel like they were pretty oblivious of the camera even being there, even though it was right there.
Yeah.
I think that brings up a good point of why it's important, and Emily, maybe you know much more about this, but why it's important to look at behavior differently in kids with Down syndrome. Because in other populations, they may care, they may more overtly care, right? But our kids with Down syndrome don't necessarily show that societal response.
Yeah, absolutely. And I also will say sometimes the camera being there was a little bit of an advantage because some of the kids wanted to make a YouTube video. So it was like capturing their attention in a positive way. So it wasn't actually going on YouTube though, because that would be very against the hierarchy, but
Other questions? Some shout outs in the chat.
Do you all have any experience coding other than this project?
No, it's actually the reason I wanted to do it, because I had never coded before. So I wanted some experience.
Yeah, same. And it just seemed very interesting to code his behavior in general, but no previous experience. It's been fun. And it's not easy, as opposed to what most people think. No, that is not easy.
Not as, or
and it's so sometimes I agree.
Yes, we are all three in different areas, but that's great because then we get to talk about it, and there's some group conflict, and we come back together.
Great. Well, thank you all. It's awesome. Oh wait, Nicole says maybe she missed this, but do you plan to look at relationships between how parents interacted with their kiddos and their kiddos' behavior?
Kelly, do you want me to answer? So yeah, we'll compare this. Sorry.
No, I was just going to say we definitely are looking at both because it's very interesting to see how some parents are fully engaged and maybe more helicopter compared to some parents who are like sitting back and letting their kids do. So we are definitely looking at both of those.
Yeah,
Ray
and
can
we'll
add
have
any.
some fun, nice graphics too, hopefully for the poster to be able to, the system software does a lot of really cool like visualizations of the coding. So we'll be able to see like, oh, there's a lot more parent behavior here because there was a lot more child behavior over here. You know, we'll be able to look at how those things intersect.
And also, Courtney, I would love to hear more about your coding with flies.
Thank you, guys. And it's so cool that we've heard about genetic syndromes throughout this afternoon so far. And we're going to shift gears and still talk about coding, but jump into autism with our team's project. So whenever you guys are ready.
Can you guys all see it okay? And I think James is going to kick us off.
All right, so our project is looking at different racial and ethnic disparities within the diagnostic process of autism spectrum disorder, or as we'll call it, ASD, moving forward. So Kelsey, if you want to hit the next slide. All right, so we want to start off with just going through some quotes that highlight some of the experiences that racially and ethnically minoritized families have as they are receiving the autism diagnosis for their children. This first quote here highlights how oftentimes these families can receive multiple diagnoses before they are given the autism diagnosis, even though that autism diagnosis probably is the most accurate diagnosis. They're just being kind of sent around chasing doctors, receiving all these other diagnoses that don't quite capture their children's difficulties. And then this quote, as well as the quote next to it or below it, are showing that oftentimes these families are experiencing their concerns being minimized by the providers that they're trying to seek these services from and get these answers from. Perfect. And then this slide's demonstrating how a lot of these families experience provider bias when they are receiving care. And sometimes providers make assumptions about their backgrounds and their abilities and what their situations are just based off of the racially or ethnically minoritized identities rather than the information the parents are actually providing them. So we know that within autism, there are these racial and ethnic disparities. So importantly, children of color are diagnosed later than white children. And this is despite the fact that there are no differences in terms of symptom onset and symptom progression. They're just not being diagnosed as soon as their white counterparts. Also, these children, as I mentioned earlier with that first quote there, they're more likely to be misdiagnosed with other mental health conditions besides autism, even though it is autism that they're presenting with. And then lastly, they're also less likely to have culturally responsive care. And by that, we mean care that is sensitive and adapted based off of those cultural differences that are present. However, even though we know that these disparities exist, most of the studies looking at dissatisfaction with that diagnostic process have underrepresented the very families that have these greatest disparities and the most dissatisfaction with this process. So our research questions are twofold, and we're looking at these questions within the context of the Kelly O'Leary Center here in DDBP. So a lot of the data has come from the ADAM network, which is let me remember myself on the name there. It's the Autism and Developmental Disabilities Monitoring Network. So it's a 11-site national project looking at autism diagnoses, primarily in the schools, although now they are getting healthcare diagnoses as part of this network data. And so because all of the information is not from this medical setting, that's why the study is really important, because we are right here within our division looking how this process unfolds. So our two questions are, one, are there racial and ethnic differences in family satisfaction with the diagnosis process of ASD? And other team members are going to be talking about how we're looking at that and how we're getting that family satisfaction. The second question is, are these differences also present in the number of recommendations and referrals that families are receiving within the diagnosis process when they receive the autism diagnosis for their child? So with that, I'll pass it along to Kelsey.
So how we are going to kind of get to the bottom of these research questions. We started with a literature review just to kind of get us all on the same page, where we learned a lot of what James informed us all of on the first few slides. We've also been doing chart reviews, and as you can see, that is an ongoing process, which is why it's on the side there, going all the way down. So far, as a team, we've done about 10 to 12 chart reviews a person for a total of 40 to 48 as a team. However, there are a total of 317 chart reviews to do. And I'll point out that this is part of Allie's Fisher's dissertation work. So you guys all met Allie, and she has been absolutely wonderful, and she's done a lot of these chart reviews on her own as well, and has been a great resource to help guide us through this process. So along with the chart reviews, we are developing a questionnaire, and in doing so, we have used the help of our wonderful policy partners, including, and I apologize because I will probably pronounce their names wrong, but Kelly Kamamira Nishamera and Tanya Freilich have done a wonderful job of helping us on the scientific side of things and making sure that we're covering all of our bases, making sure that we are making a questionnaire correctly and logically. Everything's formatted the same way, using the same kind of language. And then we've also used the members of Autism and We, their core members, and they have been a great asset because they've been able to look at our questions and tell us from a parent perspective, is this something that's important to us? Is this in language that we can understand? Should we ask it a different way? Is it offensive? So they've been able to help guide us in that sense. And then also the Autism and We facilitators have been helpful too. We did have to get IRB approval for this project, and we are currently, where the star is, working on distributing the questionnaire. We'll be calling people and sending that out. It'll be a red cap survey. And then once we finish the chart reviews and get all of the data from the questionnaires back, we will, of course, do a data analysis. So looking more at the questionnaire, the first part will be the demographics part, and this will actually, for the most part, be done over the phone. We are going to call the parents because we feel that this is more personal. We can ask them what language they prefer the survey to be sent in, and we can ask the questions that are more sensitive over the phone. For example, we are going to ask, what race do you identify with? We're also going to ask, what race do other people perceive you as? We're going to ask, what language do you speak? And some of these questions don't have a straightforward answer, and they're not something that you can just click a box for. So we really wanted to give the opportunity for them to talk to us over the phone to provide those answers and then obtain consent. We're also going to be talking to them about the path to diagnosis, and this will include everything from the evaluation process, from the referral to walking in the door, how they felt the clinicians worked with them, if their questions and concern were heard during the evaluation, and if they left the evaluation feeling like the clinicians really knew their child. And then we're going to talk about the information sharing session, or the ISS, and we're going to ask them how it was to receive the diagnosis. Did they understand the diagnosis? Did they have questions that were not answered? Did they know what the next steps were? And how satisfied they were with that process. We're also going to ask them about referrals, and if they were satisfied with the number of referrals that they received, and again, if they knew what to do with those referrals, who to contact if the referral place or company or agency was going to reach out to them, or if they had to take the initiation of calling a certain phone number, just kind of the information that they had there.
So when we were doing our chart reviews, we know that there's a few different ways that kids can come to us through DBP. So we looked at the arena model type. So we have three kind of main ways that children present to us. The first way was with psychology, speech, and developmental behavioral pediatrician, usually within 1-day visit. So they see all of those specialties. The second arena model type was psychology and speech. So they would see those people on the same day typically. And then the third model is first you go and see a developmental behavioral pediatrician prior to getting evaluated by psychology and speech. So those were the three different ways that we would kind of code that in our chart review. We also looked at family structure. So that includes who the primary caretakers in the home are. So that's what their family looks like in the home. So how many parents are in the home, if it's grandparents, if there's foster parents, other relatives, or someone who's not related to the child who's living in the home. It also includes how many siblings they have, if they have a sibling that was diagnosed with autism in the home too. We looked at previous interventions and services. So that would include things like early intervention, any other therapies they were getting prior to presenting to us. And then we looked at standardized testing. So when we looked at standardized testing, we looked at their cognitive, what was used as a cognitive measure to see kind of where they're at developmentally. And then we also looked at whether they got an ADOS or not. So the ADOS is the autism specific, and that's the gold standard for the autism diagnosis. And then we looked at recommendations and referrals. And so that includes things like therapies. It also includes things like school services, social work. It includes strategies. So just kind of basic behavioral strategies, speech strategies that were recommended for families to do. So some of our challenges to progress. So we had a difficult time consistently identifying which recommended strategies can be implemented by a parent independently. So the way that we define strategy is we wanted families to be able to read the report and say, okay, they're saying, let's do a picture exchange where you give a picture to a child to tell them to give it back to me to express that you want a burger. And so the idea behind that is if a parent was reading this report, would they be able to actually do a strategy just based on reading this report? And that's how we define strategies. We really wanted the parents to be able to kind of take it and run with it. So we had a hard time identifying within the reports whether families would be able to do that with the limited information that is sometimes in the report. The other thing that we had that was a challenge to progress was waiting for approval for group members to be added to the IRB, which sounds like that was an issue kind of in various projects too. So that was a different thing for us too. Just the sheer number of chart reviews. So we had mentioned that it was about 300 plus chart reviews. So that's a lot from the time of 2018 really was the year we were looking at. So that's really how many kids come through DBP to get diagnosed. And that's just a very big volume for us to kind of get through. And we really had to do a lot of hunting through various notes. And then the complexity of chart reviews. We know that people can disagree about strategies. Just being consistent across different reviewers was important. And so we did have to kind of be talking throughout to kind of determine how we were doing these chart reviews. So the timeline moving forward. So we are hoping to collect our questionnaire results. So that includes the phone questionnaire and then also sending it out to them with a red cap survey. The other thing is to finish up our chart reviews. So we have quite a bit of work to still be doing. And then to do our data analysis. We hope to present at the CCHMC Town Hall on April 12th. And then we were hoping to do our poster session on April 14th.
Our MCH competencies were self-reflection, cultural competency, family professional partnerships, interdisciplinary, interprofessional team building, working with communities and systems, ethics. Next slide. And our next steps, we'll continue our data analysis. We'll prepare our manuscripts for when we call our parents, and we'll all remain advocates of anti-racism.
All right, so as we were going through this, there's a couple of key important takeaways that we wanted to kind of bring to everyone's attention because these are things that we can always improve on for anyone who's in a provider role. And first and foremost is that there really needs to be this increase of diversity among testing and treatment materials. And so I'm not sure about other disciplines, but I feel like I can speak on behalf of psychology, and it's been pretty slow trying to improve the representativeness of the materials that we use in testing, and also the materials that we give to parents as part of our recommendations and different interventions. And alongside that, it's also really important to make our language more accessible and more succinct for our notes that patients read or that patients' parents read or caregivers read, and also in our interactions. So it's something that we noticed, and it's one of the challenges for determining if something would count as a strategy or not as part of our coding is determining maybe we can understand what this means because it's a speech recommendation. So Kelsey is really familiar with what the content is, or it's a psychology recommendation, or it's a pediatric recommendation. And so as providers, we know what those mean, but is that something that a parent would know and could follow? And Risha was a huge advantage with this and giving us that parent perspective and letting us know, are these things that, as a parent, do you know what to do if you just read this one thing? And so Risha's been an invaluable member of our team with that perspective. So I just want Kelsey just kind of quickly go through the next 3 slides here, but as you can see, these are examples of visual schedules. So something that we often recommend for children with autism to help them with transitions. And these are not very diverse at all. I think across those 3 slides, those like 3 images, there's maybe 3 or 4 non-white figurines or like cartoons there. And this is something I've had a hard time with some of my patients, trying to find pictures to include in reports or examples that truly are representative and aren't just a bunch of white cartoon figures. So this is kind of what we mean by increasing the diversity. All right, so now these are some examples of some of the strategies that we are providing in reports, or that were being provided in reports back in 2018 that we were reviewing, and so we're trying to determine, are these things that parents can read and know what to do? And so we'd like you guys to take a stab at this and reading through the slide here. Do you guys think that this is something that if a parent just read through the report and this was the information that they had, are they able to implement this at home with their child? Should we count this as a strategy or not?
And then just pop in the chat like a yes or a no, or if something sticks out to you or you have any additional comments.
All right, so people are saying it's confusing, it's very intense, a lot of information on there, pretty long. And team members are going to probably have to help me. I honestly forget if we count this as a strategy or not.
I honestly think we did. I think we did.
When we were looking at it, we were thinking of, from a parent perspective, can you read this and know what to do from it? And we decided, yes, you can read this and you can know what to do from it. But we also talked about how it would make a parent feel reading about, when your child's being physically aggressive and everything like that. And while we counted it as a strategy because it met the criteria that we defined at the beginning and we wanted to be consistent, we did have a really long conversation about it and talking about how it could make a parent feel.
Yeah, I think we ended up counting it because it provides specific directions for what to do. And yes, it's very long, but if you broke it down like each individual thing, then it clearly outlines what each like step is, and so therefore it would work. 2 minutes.
I apologize if this is where my brain is a problem by the end of the day, because I was not looking at the timer. I was listening. So you guys have 2 minutes.
Right. Well, this is kind of our last thing here. So, but we just wanted to highlight some of the challenges that we were having in making these decisions.
I just had something quick to add, because it just reminded me of the behavioral treatment plans that I write up in my clinic with Dr. Laura, and how we try to make sure it's brief but to the point, and making sure, like, instead of saying physically aggressive behaviors, we're like listing the specific behavior that we're actually looking at. So whether that's kicking or chinning or grabbing, but not like being so vague. And also making sure there's bullet points where, you know, instead of that long paragraph of this is what you have to do, just like having it simplified. So like grab a toy, grab a file folder so that you can use redirection, or maybe you need 2 people for blocking and redirection and how that may look. So.
Yeah, and Megan, consistent with what you were saying, I know some families who would struggle with identifying what deflect means, what blocking means, because they may interpret that in how they identify what the word blocking means, and may not understand what deflect means at all. So, you know, typically when I've had work in the community, instead of using such words, I will do a description and then put that word in parentheses so that it was a learning opportunity as well. So, you know, but I don't know that standalone deflect. Some parents, yes, especially those who are educated with post high school, but some others may not. So what happens is, then they don't follow through, and then we identify the parents as non-compliant or non-cooperative, and it's just they were lost from the beginning.
Yeah, that's some of the questions in our survey are getting at that. When parents receive the reports, do they feel like they have the skills and the information to afford, or do they feel like it was just too much and they were overwhelmed by the amount of information in the report, or the type of information, or how it was presented? You guys raised excellent points.
And I do want to point out, I'm seeing a lot of comments about bullet points, and we all actually talked about that too, and we agree. And when we do give our talk at the town hall, for example, we're going to share with everyone, you know, things that stuck out to us that were confusing for parents, and suggestions for what could be better to portray the information to parents, and all of the results that we have, of course.
And I know.
So, yeah, no, go ahead. I think I'm just going to go ahead and say that we're into the question and answer period.
Sorry.
So go ahead, Megan.
I know I missed pretty much all of your presentation. Sorry, I was at an open house. But also something we do in my clinic is making sure that before we even, you know, implement the treatment plans or the intervention plans, like we make sure the caregivers are looking over it, and we kind of do like a run through in the clinic, and they let us know what language is appropriate, like this doesn't make sense, so let's change it to this to simplify it too. So making sure that the caregivers feel like they have a voice and a say in their treatment, because we don't know what goes on in their homes. Only they know that they're the experts. So.
Did anybody else have any questions about the presentation or our project?
Well, thank you everyone who presented today. Those were awesome updates on your projects. Yes, Donna, I like this. And so going back to the poster session at Ohio State that Elodie alluded to. So as with most things, we are going to have an opportunity to again present our work virtually, because Ohio State has gone back to basically a shutdown for their size of meetings. So they cannot accommodate us up in Columbus. And so we are going to be working with the directors, I think next Monday, the Monday after, to start to determine how we can do this virtually for the third year in a row, but make it fun for you guys and interactive. So we may tap some of you to help us with the planning and get some ideas. If you're interested in sharing ideas and just being on the planning committee, please just don't hesitate to email me, let us know, because we want to make it worthwhile for you. But unfortunately, we are going to have to do it somewhat on a virtual format because we won't be able to be in person on their site. And if we can't be in person on their site, I can guarantee you we wouldn't be able to be in person on our site either. So that's that. Any other questions?